Good afternoon, everybody. My name's Dr. Frost. I'm a consultant gastroenterologist that works for Russell's Hall Hospital within the Dudley Group NHS Foundation Trust. It's my pleasure to speak to you all this afternoon on neuromuscular gastric dysfunction and enteric dysmotility and the role of scintigraphy in managing these conditions. Many thanks to the BNMS and Dr. El Said for inviting me to talk today. It's quite a short amount of time to talk about both of these subjects, so I'm going to try and keep it sort of clinically focused and where these tests may have a role and some of the pitfalls in management of delayed gastric emptying in particular. So to start off with, I'd like to just mention that there are no declarations of interest and nothing to declare today. And I'm going to start off by reviewing the indications for gastric scintigraphy, and this is as per the BNMS clinical guidelines. So we know that the conditions that are investigated are possible gastroparesis, so suspected delayed gastric emptying, endoscopy negative functional dyspepsia, which I'll talk briefly about later, dumping syndrome or rapid gastric emptying, possible gastroesophageal reflux disease, although again, I'll go on to talk a bit more about that later. And then some of the other indications are those with persistent symptoms after gastric surgery, potentially as a follow-up scan to assess response to therapy, and those for motility studies for drug and physiological research. The ones that I've highlighted in red are the ones that I think there is potentially a role for gastric scintigraphy. There's definitely a role in motility studies for drug and physiological research, but that's not something that we do day to day. And certainly in the majority of district general hospitals, you're not going to see studies like that being performed. And we don't really use it to assess whether there's been an improvement in therapy. And that's because a lot of the drugs that we use for this probably don't actually improve gastric emptying that much. Certainly the doses that we use, the evidence for them actually increasing or decreasing gastric emptying time is not very robust. And I'm not sure that we necessarily do it that often post-surgery other than in the bariatric setting, and that's predominantly for sort of dumping syndrome diagnoses, which you can usually make clinically, though it might be important in those that have had fundoplications, and I'll talk about that a little bit later as well. So to start off with, talk a bit about gastroparesis. So I'm sure you all know about gastroparesis. It is a difficult clinical syndrome to manage, actually, and it's very heterogeneous disease. It's not always predictable in who will respond to certain treatments. And that's probably because there are lots of reasons why people have symptoms of bloating, postprandial fullness, early satiety, pain, and nausea and vomiting. I think one of the easiest things to measure to tell whether someone's got a sort of gastric dysmotility is delayed gastric emptying. And at the moment, that is one of the sort of threshold for making a diagnosis of it. So you need to have evidence of delayed gastric emptying. But delayed gastric emptying is probably not the only pathophysiological mechanism that causes symptoms in this patient cohort. Actually, we know that some of them, a small proportion, will have pyloric dysfunction where it doesn't relax properly, and that might then lead to a delay in gastric emptying. And some people have a failure in accommodation, so the top of the stomach fails to relax when food enters, and that can cause pain and feelings of bloating and fullness. So it can be difficult to know how to interpret, that really. And in order to make a diagnosis of gastroparesis, at the moment you need evidence of delayed gastric emptying, so we need a good measure of determining how that is. And it has to be in the context of those typical symptoms. And because there's a lot of mimics of gastroparesis, functional dyspepsia being one of them, cyclic vomiting syndrome being another, patients who've got eating disorders, they have to have typical symptoms of vomiting and regurgitation, because without that, it's really really hard to make that diagnosis, and it also has to be in the absence of mechanical obstruction. And we know that although sort of diabetic gastroparesis is probably the disease that we recognise causes problems most often, actually the vast majority of gastroparesis cases are idiopathic, and whether they're truly gastroparesis or disorders of gut-brain interaction remains to be seen, as the studies have not always sort of excluded those biases really. Assessment of gastric emptying, won't go over this too much, but essentially we used to, pick it up on, somebody got evidence of food residue in their stomach, but that's not very accurate. And actually the sensitivity and specificity for that is only 55 and 72% respectively. There are other tests that can be done, but a lot of them use liquid, and we know that liquid leaves the stomach passively using gravity. Actually, if you want to know if the stomach's not working, we want to know whether trituration is failing, and actually you need solids in order to measure that. So barium meal can sometimes give you a clue, but again, it's not particularly accurate. And so gastric scintigraphy is probably the most widely and easily available measure of determining gastric emptying accurately. So gastric scintigraphy, we use it quite a lot to help measure gastric emptying, and it can be very helpful. What bit do you use? And there's lots of different measures of assessing this. You've got your half-life, your peak gastric emptying time, your residual volume at certain hours, and then there's whether there's a delay and lag time. And I know that has caused a lot of sort of clinical interest as to whether it does or not, and I think the jury is out really. I don't think there's any good evidence to suggest that lag time actually matters with regards to clinically how you manage these patients, with the exception of obviously it's really important when you're designing new drugs essentially. So a lot of the prokinetics like domperidone and metoclopramide that we use affect the lag time. But actually, if you look at a lot of the drug trials using those medications in treating gastroparesis, the evidence is not very robust. And actually, I don't think there's great evidence that they work at all. Certainly, the doses that you have to use to actually improve gastric emptying are much higher than those that we use in clinical practice. And if you look at a lot of the trials where people do find symptomatic improvement, they are on doses that aren't high enough to actually improve gastric emptying time. So they might be working there through either placebo or from antiemetic effect rather than improving gastric emptying. Lag time with regards to different disease processes, well, actually, there isn't a lot of evidence or information on this out there. From my literature review, diabetic gastroparesis can show a delay in gastric emptying through lag time being prolonged, but actually that gastroparesis also shows generalized delay as well. And I think knowing how much food is left in the stomach after a longer period of time is more clinically relevant than knowing whether things are leaving in the initial kind of half an hour to an hour. And so I'm not sure that it has a role in those with suspected gastroparesis, but obviously in calculating the lag time is quite helpful to not miss rapid gastric emptying. And bear in mind that although you might think the symptoms are different, they're actually very similar, and sometimes patients presenting with bloating, upper epigastric pain, nausea, that can be a sign of early dumping syndrome. And so actually knowing how quick the stomach starts emptying in that scenario can be quite helpful. So actually what's more valuable for me as a gastroenterologist is knowing what the retention value is. I think this is the most accurate and certainly most clinically useful measure. And obviously we've got various numbers there, as you can see, and I'm sure you're all familiar with that. Now, the problem with knowing the gastric retention value is that obviously that's a long study if you're doing a full 4-hour study. And obviously with resource and allocation time, for these studies, it's much better as a department to do them quickly. And so the standard and the habit has been that you get a 2-hour one, often it's a 90-minute test. And actually, that's got really good sensitivity. So if they've got delayed gastric emptying, it's going to pick it up. But the specificity of a 2-hour measurement is absolutely terrible. So the false positive rate of a 2-hour gastric retention value is 80%. So that is not helpful. So actually, 4-hour measurement, the specificity improves quite much more. And I think, there should be really, I think ideally we should be aiming for 4 hours when we're doing a gastric emptying study. I recognise that that might be quite challenging to achieve, but if we don't, there's a high risk that we're overdiagnosing gastroparesis, and that does have clinical significance because some of the procedures that we do for delayed gastric emptying are quite invasive, and actually, if they don't have an accurate diagnosis, then we're potentially subjecting patients to iatrogenic harm. How do we manage gastroparesis? Obviously knowing whether they've got gastric delay, we can't make a diagnosis without it. But actually, if they've got delay, is that the best thing to target? Well, probably not. As I've said, we know that the drugs don't really work that effectively, and they might work more on antiemetic perspective rather than prokinetic. In my opinion, this is a long-term condition, and actually the chance of cure is extremely low. So most of these conditions, take diabetes for example, it's not going to get better. They've developed autonomic neuropathy driving this, and so they're going to have to live with these symptoms forever. And we can ameliorate them to some degree, but they always have a degree of nausea and vomiting, and that's quite hard for patients. So setting that out early is really key, and paying attention to psychological distress and any social deconditioning that might occur is really key to improving well-being as well. And we know that actually if you are psychologically distressed with poor social functioning, then actually your gastrointestinal symptoms are likely to be significantly worse. So don't ignore the role that has to play. And in my opinion, dietary modification is by far the best management strategy. And we try to avoid artificial nutritional support wherever possible, because tube-related complications are quite high in this cohort of patients, particularly the ones that have got idiopathic gastroparesis. I find that effortful oral feeding is the least worst option, and trying to get that into patients' heads can be quite difficult sometimes. Obviously, fats and fibrous foods sit on the stomach for longer, so caution with them. Obviously, if you reduce all the fibre from their diet, they're going to get constipated, so you need to pay attention to that. And actually, sometimes if they're flaring, going to liquids, because we know that they pass through unimpeded most of the time, might be the correct thing to do, and prescribing them oral nutritional supplements can be helpful. We do try the drugs, the evidence isn't great, but some people do find that they can be quite helpful. Problem with metoclopramide is it can be quite effective, but if you use it for long periods of time, it has this horrible risk of tardive dyskinesia. So we don't like to do that. If patients do respond to metoclopramide, they normally respond to domperidone as well, and that tends to be a safer alternative. In my experience, doses of 30 milligrams or less very rarely prolong the QT interval, but normally if they do respond to that, I do check their ECG to make sure it's safe to continue, and obviously you instruct patients and general practitioners that if they're starting new drugs, they might need to be aware that it might affect the QT when co-prescribed with domperidone. Prucalopride is the new kid on the block. That's quite effective, improving gastric emptying, and also helps those that have got concomitant constipation. So that's quite a nice drug to use. And if patients are in hospital with a flare, then intravenous erythromycin can be really useful, but you can't use it for long periods of time because the effect wears off. It demonstrates tachyphylaxis. You obviously, in those with diabetes, optimizing glycemic control is key because that will minimize symptoms, and make sure that you are objectively monitoring for dehydration and malnutrition. Interestingly, despite nausea and vomiting being a frequent problem, most patients maintain weight, but they will have problems with dehydration. They can have acid-base balances due to loss of hydrochloric acid, and sort of typically they have potassium issues as well. If medical management is not working and we're confident that we've got delayed gastric emptying with typical symptoms and diagnosis of gastroparesis, then there are more invasive treatments available. G-Poem is probably the new kid on the block, which is showing some promise. That is an endoscopic myotomy of the pylorus, and that has shown improvements in patients with all forms of gastroparesis. Botox is something that I try if it's post-surgical. The feeling is that they may have had a vagal nerve disruption leading to some pyloric dysfunction. And if they respond to Botox, then that normally wears off after 3 months, and I would then probably refer for G-Perm after that. Gastric pacing, the jury is out. At the moment, it doesn't have a role in general management of gastroparesis, and it should really be restricted to trial studies. Actually, there aren't great studies looking at this, but there is one randomized control trial, which was the WAVES trial. And actually, interestingly, patients reported an improved vomiting frequency when the device was on. It didn't actually have any clinically significant improvement in the gastric emptying rate. Again, it says, goes to show that, delayed gastric and improving gastric emptying time, does it really modify the disease and the clinical symptoms? I don't think it does. And the reason why this might have worked is because it's attenuating the kind of nervous impulses from the stomach to the brain, and it might be having more an effect of visceral hypersensitivity rather than actual delay. But again, the jury's out with regards to that. So moving on to other conditions. So gastroparesis mimics. Functional dyspepsia is the main one, and that can be subcategorized into something called the epigastric pain syndrome or postprandial distress. And postprandial distress syndrome is the condition that we see the most of, and it mimics this, with the exception that nausea and vomiting aren't particularly predominant symptoms. This is typically mistaken as gastroparesis, but this is a disorder of gut-brain interaction rather than a true motility problem. About a third of patients with this will have delays in gastric emptying. They're usually mild to moderate, and that's why it often gets misdiagnosed as gastroparesis. But actually, psychological strategies such as hypnotherapy, cognitive behavioral therapy, antidepressants such as mirtazapine have more of a role to play in this because they relax the stomach and allow it to accommodate more food. And this is definitely a condition where you're getting visceral hypersensitivity as the stomach stretches. You're getting signals sent up to your brain that it's full too quickly, and that does respond well to kind of psychological management, as I've spoken about before. You don't need invasive measures or drugs that might cause problems with your QT interval with this condition. And there's actually quite a few mimics of gastroparesis. So there's a number of disorders of gut-brain interaction, postprandial distress syndrome being the main one, but rumination syndrome, where people eat and regurgitate almost immediately, that can present as gastroparesis. Cyclic vomiting, you can get delays in gastric emptying during the emesis phase. Cannabis, eating disorders. So, if you've got someone who's losing a lot of weight quite quickly with nausea and vomiting, with only mild delay on their gastric emptying and low BMI, you've got to have a really high index of suspicion for disordered eating in those patients. And obviously, opiates and other drugs as well can delay. If you look at a lot of the gastroparesis studies, I think there was a systematic review of lots of patients with gastroparesis, and in those studies, about 30% of the patients were either on chronic or intermittent opiates. So, it completely confounded your study already. And actually, it's probably best to think of gastric emptying as a spectrum of dysfunction, really. So, on the left-hand side, you've got the pain syndromes of epigastric pain, and you progress more to gastroparesis with predominantly motor symptoms. And as you progress along that spectrum, you get increased delayed gastric emptying. So I've already spent about 20 minutes already on this. I haven't got a lot of time left, so I'm going to rattle through the next bits. So rapid gastric emptying, is it relevant? Well, maybe, and the indications in the red box are probably the main ones. So we see it following bariatric surgery. That's the one everyone's familiar with. But actually, a third of patients that have fundoplication get diarrhea, and in those patients, it might be due to the loss of reservoir as the stomach's wrapped around the top, and you can get a pyloric dysfunction as well. So they can have rapid emptying. And we're increasingly seeing idiopathic rapid gastric emptying in those patients with postural orthostatic tachycardia syndrome. So as food rushes into the small bowel, you get a lot of blood supply to the small bowel, makes the dizziness worse. We see this in a lot of our hypermobility spectrum disorder patients, and it can be a real challenge to manage. There's no licensed treatment for this. It's very tricky to know how best to do it other than changing the way that people eat. So there's dietary strategies that you do for dumping. We know that acarbose can sometimes help slow down the rate of carbohydrate absorption. And I think there's going to be an increasing role for some of these new drugs, these GIP agonists like Mounjaro and Ozempic, because they do delay gastric emptying. And I have anecdotally used these drugs in patients before, and they do notice an improvement in diarrhea and those sorts of dumping syndrome symptoms. Finally, we've got gastroparesis-associated reflux. I don't think it has necessarily a role in determining whether someone's refluxing. You know, pH testing is much better than that, but we know that about up to a third of patients with gastroesophageal reflux disease might have concomitant delayed gastric emptying that might be driving it. And obviously, if you've got atypical symptoms, so bloating, nausea, vomiting, postprandial fullness, you should think about whether that might be a problem, particularly in those patients that you're thinking about surgically managing. You know, we know that if you've got delayed emptying with reflux, you're less likely to completely respond to proton pump inhibitors. Actually, the patients that respond best to surgery are those that do respond typically to anti-reflux drugs and don't want to take them long term. So anyone who's got partial or incomplete response with evidence of pathological reflux, if they've got any of these symptoms, particularly if they're diabetic, they should be thinking about checking their gastric emptying times, because they will have a poor response to surgery and they might get gas bloat syndrome if they are fundoplicated. I'm not going to talk about enteric dysmotility too much. We don't use a lot of small bowel scintigraphy in district general hospitals. I have requested a few in my time for indications I'll go through momentarily. Enteric dysmotility is really difficult to diagnose, and I don't think we do. The most obvious form of enteric dysmotility is when it gets to end stage dysmotility and they develop chronic intestinal pseudo-obstruction. That's very obvious on X-ray. They've got dilated, fluid-filled small bowel with no mechanical obstruction on CT, and that sort of, it's fairly easy to manage. But those patients who've got early kind of neuromyopathies, the best way of determining it is probably with abnormal manometry, but that's not widely available. It's painful to do, and actually there's no real normal reference ranges. We don't quite know how the small bowel works. You know, it will freeze for a moment, it'll mix things up, it'll move it back as it churns it down. So and then you'll get this migrating motor complex. It's really difficult to know what the variation of normal small bowel motility is. Scintigraphy can help in the absence of manometry to help work out. And I would say that, you know, if you've got dilated small bowel, you're not sure whether things are moving through, then it might have a role in helping you to determine whether it's global dysmotility. Patients who've got scleroderma with bloating and gut symptoms, that might be quite helpful. Recurrent small intestinal bacterial overgrowth, you know, is it because things aren't moving through very well and things are stagnating? Autonomic enteric neuropathy and impaired jejunal feed tolerance. So, you know, patients with hypermobility spectrum disorders aren't tolerating feed, and actually small bowel scintigraphy, if they're able to tolerate that, might help, because you're then helping to determine whether it's enteric dysmotility or whether it's just visceral hypersensitivity as the cause. And probably the main indication is ahead of planned surgery for chronic medically refractory constipation. That's probably the most likely cause, because you don't want to be thinking about ileostomy if the small bowel and stomach don't work, because they'll just have stoma dysfunction. So you're replacing one problem with another, essentially. And drug trials. Again, it's a complex thing to measure. For reasons that I've explained before. We know there's anterograde and retrograde movement of intestinal chyme, and some areas go more quickly than others, and then you get this periodic migrating complex. But the simplest conceptual approach is to see how quickly it arrives to the cecum and measure the oral-cecal transit time. Looking at that, the reference range is probably 72 to 392 minutes, the longest time just being shy of 6 hours. Another way of measuring it is to determine how much has reached the TI after 6 hours. And actually, generally, it's normal if more than 40% of the administered activity has progressed into the TI. Everything is kept there. There's a natural break with the ileum. So as long as it's reached the internal ileum or passed into the cecum at 6 hours, that's fairly normal. So I think this is what we generally use. And that's sort of a measure of whether you've got sort of normal or abnormal small bowel transit time. I'm going to leave it there. I've overrun by a little bit, so apologies for delay, but I'm happy to address questions at the end of this session. I hope you found it helpful. Thanks very much.